Good morning. This is Steve Williams. I'm the Chief Operating Officer for the Alaska Mental Health Trust. I'd like to welcome all the folks that have attended to participate in today's first of a three-part webinar series to gain a better understanding of what the Medicaid block grant program is, how it's structured or could be structured, and the services that could be provided under this one particular approach to the Medicaid program. The Trust engaged in hosting this series from hearing input from stakeholders around the state who wanted to understand more about what a Medicaid block program, grant program is. So we heard that, and we tried to develop a series that would provide some basic understanding about the program itself, and looking at the program from a bunch of different perspectives. And so we have three individuals who I'm sure are going to introduce themselves a little bit online, but I want to thank Steve Letsky, who has been, formerly worked for CMS, but has since helped many states look at their Medicaid program and assess how to best structure their program and provide services that meet the needs of individuals. And then we also have Andrew Schneider and Dennis Smith, who will be panelists who will talk about the program. So I want to thank Andrew, or Andy, and Dennis, and Steve. We're all in different locations. I'd shake your hand, but I'm going to just say thank you over the line. And I'm going to turn it over to you all so that you can start this program, and we're looking forward to learning from you. Thank you.
Okay, this is Steve Letsky with HCBS Strategies. We have broken this into three sessions. Today's session is going to be giving you kind of a 101 about what Medicaid block grants potentially could be. There are two major components within, if you're going to be setting up a grant, and one is on the budget neutrality and the financial parameters. So session 2 is devoted to that, and then the session 3 is what are the actual components of the block grant. So that would be in CMS parlance talking about negotiating what are the terms and conditions in terms of what the state would be allowed and not allowed. We are not in decision makers in this. The state will be making the decisions. So as far as giving us advice about things that should or should not be in the block grant, we certainly can hear you on that, but we will not be the ones who will be making the decisions. What we will be doing is helping to educate you about the process of negotiating this within CMS and what can and cannot be done if a block grant is going to be done under a current Medicaid authority. Now, in terms of the format for the meeting, we have a large number of people on here. So far, we're up to 192 attendees, and we thank all of you for attending, and we want to make this as meaningful as possible for you all. In this one, what we're thinking is that we're going to have the presentation that'll be roughly about 45 minutes, and that'll be Andy will be the lead presenter, and Dennis will be providing commentary on that. The rest of the time is going to be for question and answers. We're envisioning that for the next two sessions that we'll spend about a half an hour on the presentations and more time for question and answers. So if you have questions that are not answered during this session, that you'll have the two other sessions to ask additional questions. Now, for entering questions, you have the Q&A button that you should be able to see at the bottom of your screen. There's that box that says Q&A. When you click on that, you can enter a question at any time. And as we're doing like the initial presentation, it would be great if you start to enter questions that you would want to have answered. We won't be answering them in the initial 45 minutes. We'll be saving those for the latter part of them. But when you enter that, it'll be very helpful if you are able to see if there's any current questions that are open and you know, if your question has already been asked by somebody else, you can click the upvote button. The upvote button is that little hand that's kind of associated with the thumbs up. So if you click on that, and I noticed somebody just actually, 2 people or a bunch of you are really getting it because you're really upvoting the question that is currently entered within there. So that'll help us to kind of recognize which of the questions that are most interest to all of you. You can potentially then, like if there's a clarifying point that you want on an existing question, you can add a comment on that and to ask a follow-up or to clarify that. Now, we believe that there are some people at the Trust who will be able to ask questions directly, and that Kelda and the members of the Trust in the room will be facilitating that. We'll be opening their microphones for them. We're going to be reviewing the questions, trying to group them as possible. We're going to be marking some of the questions that are answered as answered. If you don't believe it's answered, then you can ask the question again and add it again, possibly rephrasing it. If when there's your question that is up and we're not clear on a component, or if we want to check that there's an answer, we may ask you to raise your hand, and that is another one of those icons that should be at the bottom of your screen. But also when your question's being asked, and if there's really a clarifying point that you want to ask about it, you can raise your hand then, and then we can open up your microphone. An important thing to note that if you're dialed in on the phone and not using your computer audio with the computer microphone, we won't be able to hear you. So it'll only be if you have a microphone via the computer. But if you are dialed in on the phone, you still can ask the questions via the question and answers. And we do have an awful lot of people, so I don't think that we will get to every question. So now I'm going to move on to the speakers. We've got 2 great speakers today, and in talking with the Trust to set this up, we really wanted to apply some balance to this. So what we wanted to do is we wanted to get different perspectives on it, and we ended up getting one person that was very involved in the Obama administration approving 1115 demonstrations with the states at a high level, and then one person who was involved at the Bush administration, the George W. Bush administration, in playing a similar role. And both of those are very bright people who have been very thoughtful and made great contributions afterwards, and that they are in a great position to provide us with guidance on this. So the first person, and Kelda, I'm going to mute you in the room because we're getting a little bit of feedback from it. Okay, so the first person is Andy Schneider. He's currently a research professor at Georgetown University in the McCourt School of Public Policy. He's been around for 40 years as a congressional staffer in the executive branch, and a public interest attorney. He was also a senior advisor at the Center for Medicaid and CHIP. CHIP is the Children's Health Insurance Program services under the Obama administration. So that's the component of the Center for Medicare and Medicaid Services that oversees Medicaid. So he was one of the lead senior advisors during that term. He also led the Medicaid resource book for the Kaiser Commission on Medicaid and the uninsured. The second person that we have is Dennis Smith. And Dennis is currently a senior advisor for Medicaid and healthcare reform with the state of Arkansas and their Department of Human Services. He's also serving as a visiting professor at the University of Arkansas Medical Services in their College of Public Health. He's worked with Arkansas, Wisconsin, Virginia, and California. He did 10 years on Capitol Hill. And he was also in that same section of CMS, the Center for Medicaid and CHIP Services, for nearly 7 years. He was the director, and in full disclosure, he was my boss when I was there. And he was directly involved in negotiating the demonstration projects under 1115 with more than half of the states. Okay, I'm going to go ahead now and then turn this over to Andy.
Okay, thank you, Steve. And good morning, everyone. Thank you to the Trust for the opportunity to work with you and Dennis on explaining this issue. It's a very, very important issue for Alaska, as for every other state. As you can probably tell from my bio, I bring a bias to this issue. I really don't think block grants are a good idea. But I'm going to try to be fair in my presentation here. We're going to run through some slides to get everybody level set on what the components of a block grant are, how to think about it. And you basically, everybody has to have this particular set of understandings in order to go to the next two steps further down into the weeds. So there's no definition of a Medicaid block grant. You're certainly not going to find it in the Medicaid statute because there isn't a block grant. So what we've decided to do is we're just going to define it here for purposes of this webinar. And I think this is a definition that most people would be comfortable with, as a federal state program that's got three elements. So there's an annual allotment from the federal government to a state. It's fixed in advance. And it's allotment of matching funds. So these are funds that are going to match state spending on Medicaid services, whether they're medical care or long-term care services or other services. So the second element is the state is going to be entitled to the federal matching funds, but only up to the annual allotment amount. So if the state makes a qualified expenditure for a covered service on behalf of an eligible individual at an allowable payment rate, the federal government will match that. And the state is entitled to that payment up to the annual allotment amount. And the final element is there would not be, as there is under current Medicaid law, an entitlement to any individual to coverage for a defined set of benefits, whether they're hospital, physician, nursing home. There would not be an individual entitlement. So I'll just pause here for a second, see if Dennis has any comments on that. So I'm not hearing anything. So Steve, you might as well go on.
Yeah, Dennis, if you're speaking, we're not hearing you. Okay, Andy, why don't you go ahead and go on, and Dennis, if you want to check your microphone, then we can feel free to jump in.
So Steve, I'll go on as soon as you flip the slide. Okay, so just briefly, structurally, how would a Medicaid block grant differ from the current Medicaid program? How would it compare? So current Medicaid, there's not a fixed allotment. It's open-ended federal matching payments. If a state makes a payment on behalf of an eligible individual to a qualified provider for a covered service, that's going to be matched by the federal government. And whatever drives a state spending, whether it's more people, services getting more expensive, a greater need for services, whatever set of factors is driving it, the federal government matches on an open-ended basis at a defined rate. In Alaska's case, it's 50% of the cost. The federal government will match that expenditure. The state is entitled to those federal matching funds on an open-ended basis. The state knows if it makes an expenditure on behalf of an eligible person for a covered service, and the spending is otherwise allowable, then the federal government is on the hook to match it at the state's matching rate. Individual Medicaid beneficiaries have an entitlement to a defined set of benefits. Some of those are mandatory in the sense that if the state wants to participate in Medicaid, it has to cover certain services like inpatient hospital services and outpatient hospital services and physician services where they're medically necessary. States can also cover other services, but whatever services the state offers, the individual, if the individual is eligible under the state's eligibility rules, is entitled to have payment made on behalf of those services. And again, if the state comes into Medicaid, and all states have chosen to participate, Alaska started participating in 1972 and has been in the program ever since. The states, there are certain services you have to cover, there are certain populations you have to cover, and then there are also a range of services and populations that you as a state may cover at your option and receive federal matching funds for the costs of those services and populations. So that's the current Medicaid program. The block grant, again, it's not open-ended federal matching payments, fixed annual allotment, determined in advance, independent of any particular reasons that, as you'll see, that state spending might go up. It's just a fixed allotment. There are ways to get to that amount. We'll be talking about that. The state, again, as under current Medicaid law, the state would be entitled to the matching funds, but only up to the amount of the allotment that the federal government determined it was going to provide. There would be no individual entitlement to benefits. You could have, because of the limit on federal funding, states might decide they want to limit enrollment in the program in order to limit their own financial contribution because the federal government was limiting its. So there's no individual entitlement to coverage. And states would have a lot more, we use the word flexibility, a lot more discretion, a lot more choices as to which populations and which benefits to cover, what to pay providers, et cetera, et cetera. So Dennis?
Can you hear me now?
We can.
Okay, great. Sorry for technical difficulties on my end of things. If I can add just a little bit to this, and when we talk about the Medicaid program, it really is made up of a number of parts. So we can think of it in terms of eligibility, benefits, service delivery system, whether it's fee-for-service or managed care or partial managed care, financing, and administration. So again, when states think about their Medicaid program, they're thinking about each sort of one of those buckets. And we generally see Section 1115 waivers that may cover one or more of those areas today. But I also want to emphasize that under current Section 1115 waivers, states are also accepting either a fixed amount of federal matching funds, and the state is at risk for amounts above that. So in some respects, there are features of a block grant even within today where a state is pursuing an 1115 waiver.
Great. Should I proceed to the next slide?
Please. Okay, this is a very simple, overly simplistic explanation of the financing differences. As Dennis mentioned, there are different buckets here. To try to make this not too complicated, we're going to focus on just spending for medical and long-term care services. We're not going to talk about administrative costs. And we're not going to worry about whether it's fee-for-service spending or managed care spending right now. This is just about the large, far and away the largest portion of state Medicaid spending in Alaska and all the other states is going to be for medical and long-term care services and supports. So that's what we're talking about here. So here's an example. On the left, as you're looking at the slide, here's the way things currently work. The state spends $100 on a physician visit on behalf of an eligible person. The federal government will match that in a 50-50 state like Alaska is by statutory formula. The federal government will match that at 50%. So the state will contribute $50 of that and the federal government will contribute $50. Okay, so the cost of a visit goes up to $110, or excuse me, $120. And now the state is going to be paying its share, which is 50%, $60, and the federal government will pay the other $60. And the point is, under the current program with the open-ended matching at the fixed statutory rate of 50%, as the costs go up, the federal match goes up, as does the state share, as you can see that. Conversely, if spending goes down, if the cost of the visit goes down to $90, then the state share is 45 and the federal match is 45. So that's the current program. Now let's look at what a block grant might look like. Again, we're going to start with the service is 100, and the state share will be 50, and the federal share will be 50. Because under the block grant, we're not messing, for purposes of this discussion, we're not messing with the state share. State share is 50%, the federal share is 50%, because that's what the statutory formula provides in the case of Alaska and a number of other states. Okay, so then you've got a situation where the overall cost goes from 100 to 110. Now we're going to flip to an aggregate model, and we've hit the allotment of $50 for the federal government. So the federal share stays the same. If the costs go up beyond that at the 50% match rate, now all of a sudden the state share is going to go up. In this case, to 60. If you go the other route, the state has taken some cost savings measures. Its overall spending is 45, is 90. The federal share then is 45. Again, at the 50% match. You're still below the allotment amount of $50, and the state share is 45. So the difference here is if you're a state and you are worried about additional costs resulting from spending you have to or want to make on behalf of your low-income populations for health or long-term care services, you want to be concerned about how you deal with that absolute $50 limit on the federal share. Because as your costs go up, federal match won't. It will stay at 50. If your costs go down, the federal government will share in the savings. But all the upside risk of additional costs is on you as a state. Dennis, you want to go ahead?
I think you summarized that very clearly. I think we can move to the next slide. Thank you.
Okay, so I mentioned at the beginning, there's no current Medicaid block grant. There are some other block grants that the federal government makes to states. You may be familiar with the Child Health Insurance Program, or CHIP. I think it's called the Denali Kids in Alaska. This is under a different title of the Social Security Act. And you can see that it's funded for the next 8 or so years, it is going to pay out to states a total of about $18.6 billion. In the fiscal year that we're now in, there are about 7 million kids enrolled. There's also a maternal and child health block grant under Title V of the Social Security Act. This goes way back to the mid-1930s. That is an appropriated program. The current appropriation is about $678 million. And that money is likely to go in Alaska to the public health agency rather than the Medicaid agency, but you would know more about that. Similarly, there's a substance abuse prevention and treatment block grant. That's also an appropriated program. You can see that's funded at about $1.8 billion there this year federally, and that's of course to all states throughout the country. Just by way of comparison, the current federal spending, this is not including state dollars, but the current federal spending on Medicaid is about $400 billion, and the current enrollment of kids in Medicaid, just Medicaid only kids, is about 31 million. So Medicaid is much, much larger than these block grants, but there are block grant models out there that you could look to. Dennis?
Yeah, I would add just one piece, and I think this does come down to a very central point that the state will have to discuss, just as it gets discussed at the federal level as well, in that in the current program, there is growth that is automatic. The federal dollar follows the state dollar. So if the state needs to put in one more dollar, there's going to be at least another federal dollar to follow it. So in a period of growth, that is something that the states are extremely concerned about, because they're looking not only at the program for today, but what it needs to be 5 years down the road. And Andy's point in showing this slide is these annual appropriated amounts in maternal and child health and in SAMHSA grants, there's really not much growth in these programs because they don't get added to. And it is a very important point of discussion to be had.
Okay, so we're now going to talk to what types of problems would a Medicaid block grant be intended to solve, and what types of problems would it not be intended to solve. So let's start with what's it intended to solve. So states would like more flexibility, that is more discretion, to decide what populations they want to cover, what services they want to offer to those populations, how much they want to pay for the services that they'd like to cover, and which providers they want to allow to participate. Because all four of these are levers that affect ultimately state spending. If you cover fewer services, you spend less money. If you cover fewer populations, you spend less money, et cetera. Then there's the related but sort of analytically separate question about the state's ability to limit its own general fund spending on a year-to-year basis. Rather than seeing, well, we're running a health insurance program or we're running a long-term care coverage program over the next 5, 10, 15, whatever years, now we need to think about it in terms of what is the state general fund appropriation for a particular year, how much of a claim will Medicaid spending have on that? And a number of states have expressed interest in capping enrollment when their state general fund targets are being approached or are being breached. Dennis?
Yeah, if I can add just one more point on this, in that I was able to get a quick look at the governor's proposed budget back in February. I don't know what it is up to date, but I know that he had proposed a 24.5% decrease, and this is for the entire budget. So, and general revenue by 18.4%, declining by $2.3 billion. So again, we understand you're looking at these because hard choices are being made. I think the governor had proposed to cut out dental services for adults. And that historically, this is why states look towards different mechanisms. Many of you are familiar, at least, with Tenncare. The history of Tenncare started because the overall budget situation for the state of Tennessee was in such dire straits. So it is common that budget crises that states face is the trigger for why states are looking for ideas like this, or even would consider proposals like this.
So Steve, can we go to the next slide?
Yep, it should be on.
Here we go. Sorry. Okay, so there are some problems that a block grant, however it's designed, can't really solve. So there's the general inflation in healthcare prices, which affects not just Medicaid and the state as a health insurance purchaser, but also the federal government's Medicare program, the VA, the Indian Health Service, private employers, individuals. Healthcare costs are rising and rising quickly, and depending on the state and depending on the service. And a block grant is not going to solve that. Population growth in the state, or population decline, whatever's going on in a particular state. Again, it doesn't stop the state population from growing to block grant the Medicaid program, nor in terms of demographic changes does it stop the state population from aging, for example. That's going to happen whether or not the federal matching funds are limited. So one of the things, again, this will vary depending on the design of a particular block grant, but if a state is looking at high levels of uninsurance, that is, people who don't have public coverage through Medicaid or CHIP or Medicare or VA or IHS, or private coverage through private employers, or public coverage through their state employee coverage. If there are a lot of people with no coverage at all, limiting the federal matching payments to a certain amount is not going to help a state address that. Economic downturns. So states have some control over what happens to their economies, but they have no control over what happens to the national economy or the regional economy. And if economic growth slows, if unemployment goes up, et cetera, then a block grant is really not going to solve that problem either. You can argue about whether or not it would make things worse, but very hard to make the case that it's going to help a state with a faltering economy. Public health epidemics. The one that's getting all the press now, at least out here in DC, is the opioid epidemic, but there have been others, HIV, for example, and there will be more to come. And again, a block grant can't foresee those, can't react to those because the amount is set in advance. You're already locked in based on however you decide to lock yourself into a particular allotment or a particular amount of federal matching dollars. And so there would have to be some other solution to that. And then similarly with natural disasters, you know, on our side of the country, hurricanes seem to be our biggest issue, and they can wreak havoc. You know, severely damage state economies, severely damage the jobs and the job-related coverage that people have. It takes a while for people to get back on their feet. That's often when health insurance coverage is most valuable. And again, not something that a block grant is designed to solve. Dennis?
And I think Andy has summarized this very well. These are real risks that the state would need to consider.
Okay, so as you'll hear later when we get to the discussion of Section 1115, I think that the place to have the block grant discussion in our system of government is the Congress, not the executive branch. So if Alaska wants a block grant, they should go to Congress and ask for it. But I have a bias, of course, since I spent 20 years as a Hill staffer, and so I do think that Congress is where these decisions should be made. Setting that aside, there have been some efforts made to enact a Medicaid block grant at the federal level. This wouldn't be an individual state going and asking for it. This would be the federal government telling them it's a new day, Medicaid is different, we're now going to have a Medicaid block grant. This happened in 1981, 1995, 2003, didn't quite get very far into the Congress in 2003, and then, of course, most recently in 2017. And you would actually be looking at a block grant right now. We would be having a very different conversation, but for the votes of 3 senators, including Senator Murkowski from Alaska. So again, the point of this slide is just, we know how to have these conversations. We've had them for a number of decades. So far, Congress has answered no. But again, my own view is if you want a block grant, go ask Congress for it. Dennis?
Yeah, I take a slightly different view of this. And again, Andy and I have both worked on the Hill and in the executive branch, so we're always respectful of the separation of powers. My perspective, though, is much along the lines of what happened in the mid-90s on welfare reform. And where we ended up with welfare reform ultimately being passed is because states themselves began the process by asking for Section 1115 demonstration projects. And that is where we got ultimately Congress, with a Republican Congress and with President Clinton, passed welfare reform in many respects based on the prior experiences of the states working through 1115 waivers.
Okay, so has any state ever had a Medicaid block grant? No. There are some examples out there, however, that you could look to if you wanted to see experiences closest to them. So Puerto Rico and the territories, which are not states, they're not even the District of Columbia, and they have, since the Medicaid program was started, operated their Medicaid programs under fixed allotments, federal funding caps. there are lots of differences between Puerto Rico and the territories and a state like Alaska, but if you wanted to see how that particular form of a cap on federal funding has worked in a jurisdiction that's really pretty different, you would take a look at that, or Guam, or American Samoa, pick your territory. So speaking of 1115 demonstrations, which we will do at some length in the next couple of webinars as well, but in 2009, starting in 2009 for the 5 years till 2013, Rhode Island operated under what it calls the global Medicaid cap, which it got as a result of a Section 1115 approval. It ended up renewing that demonstration in 2013, but it didn't end up renewing the global Medicaid cap. So that would be one precedent to look at if you wanted to pursue this. And then currently, Utah is in the process of asking for a 1115 demonstration that imposes a per capita cap for its, I'll call it the Medicaid expansion population. These are adults, some of them parents, some of them childless adults, with incomes under 100% of the federal poverty level. And the Department of Health and Human Services, the agencies where Dennis and I used to work, they're in the process of considering that proposal and talking with the state.
Right. So the state I'm serving now, Arkansas, our Medicaid expansion to 138% of poverty, we did not do it through just adopting the state plan, just adopting the expansion as a state plan, but rather we did it through an 1115 waiver. And in that waiver, it is based on a per capita cap amount. So we have a budget neutrality cap in which the state is at risk for any amount that goes above that cap. So there are, while it clearly is not a block grant in the sense that great flexibility in all of these different areas, per capita caps within 1115 waivers are relatively well known for different populations, and that is how that is how Arkansas did its Medicaid expansion under a Democratic governor and a Republican controlled legislature.
Okay, so we're going to take a slight detour just to answer some basic questions about a per capita cap. This webinar is about a block grant. So we will come right back to it after this slide, I promise. But you should just know, in terms of the larger conversation, as Dennis pointed out, there is a conversation going on about per capita caps, and not just in Utah. So what's the difference? What's the same is there's a limit on federal matching payments. The difference is how you get to that limit. So with the block grant, as we've discussed, you're going to come up with an allotment amount. It's set in advance. However it's set, that's the amount, and it doesn't matter what happens with population growth. That's the amount you're getting. You can claim up to that federal matching dollars up to the amount, and after that, you're on your own as a state. With a per capita cap, the enrollment growth is automatically built into the limit on federal dollars. So if your population goes up for whatever set of reasons, you can continue to get federal matching dollars. What constrains you is that on a per member per month basis or per beneficiary basis, the federal government is going to limit how much it matches. So you get an automatic adjustment for enrollment growth, but you're still going to get a limit on federal matching payments, which will be whatever the per member per month is times the enrollment that you end up having in the year. So you're not going to necessarily know the amount of your limit before you run through your year in the same way you would as you would under a block grant. The other difference is in a block grant, again, as we mentioned, there's no individual entitlement to a defined set of benefits. Under a cap, under a per capita cap, eligible individuals, all those little per capitas running around, all those capitas would continue to have an individual entitlement to have payment made for the coverage that the state offers. And as it happens, just you can look at this on your own, but the Children's Hospital Association here in DC commissioned a study by a firm called Avalier, a consulting firm, that compared Medicaid block grants and per capita caps under different assumptions about inflation for kids, and looked at that on a state-by-state basis. And you'll see that the reductions in federal funding for states under the block grant are greater than under the per capita cap. And the reason for that is simply under a block grant, there's no allowance for enrollment. And under a per capita cap, there is. Dennis?
Yeah, I jumped one slide ahead with my previous comments. So if you want to rewind to my previous comments on the previous slide, we'll go ahead. Thanks.
Okay. All right. So what are the pros of a block grant? So we talked about the flexibility. Again, all this would be in an 1115 demonstration environment. This would be negotiated with the executive branch. In Congress, you'd have to negotiate it with the committees of jurisdiction. So the but the states would be looking, as we discussed, for discretion to limit eligibility, either by population or by individual. Say we'll cover kids, but we're going to have an enrollment cap. Once we hit a certain amount, then even the kid who is otherwise eligible, he or she's not coming in until we have more money. Limit the number, the types of benefits we're providing, limit payments to providers, so that, again, if you're looking for ways to constrain spending, these are your levers. And we discussed the constraint on state general fund spending. The one other potential advantage of a block grant, again, depending on how it's designed, is you could spend money on things other than medical care and long-term care services and supports. So very, very simply, because this is a little complicated area, but overly simplistically, Medicaid only pays for medical care and long-term care services and supports, nursing facility services, personal care services, rehabilitation services, things like that. Okay. There are, as many of you know, other factors that affect the health of individuals, which have become known as social determinants of health. There's some interest in applying federal Medicaid matching funds to those, like do people have enough food? Do people have adequate housing, et cetera? That's not what federal Medicaid matching dollars can be spent on. Right now, under a block grant, potentially they could be, but of course, it's a zero-sum game. If they're spent on housing and food, they're not available for medical care or long-term care services and supports. Dennis?
No, and just to add briefly again, is that flexibility and the predictability of, because again, you're going to do this typically over a 5-year period of time, so the state has greater predictability in what its budget is going to be.
Okay, and on the other side of the ledger, you've got matching of state spending only up to the amount that has been fixed, that fixed allotment each year. And then beyond that amount of federal matching dollars, no more federal matching dollars are available to the state in that year, regardless of what happens in the state. And you can go back to the slide where we talked about the risks that the state now carries as a health insurer, ranging from healthcare inflation to economic downturn, et cetera, et cetera. Doesn't matter. There's a fixed amount. You're matched up to that amount. And that's the end of the conversation. So, you know, pick your factor. You would basically be at risk for funding all of them or not. Again, that would be a call for the state. Depending on how public services are financed in Alaska, one option for a state is to shift the cost downstream to counties or municipalities, or to private sector organizations. But the point about the block grant is the federal government would no longer be participating after that fixed amount. I'm done.
Again, that is the risk, and that's what the state has to consider. I think it does force everyone to the table to make very tough decisions, but it is about managing that risk.
Okay, so I'm not going to run through all of these little boxes, but I would encourage you, if you, as you think about whether a block grant is good for Alaska, to start asking some of these questions, because there's lots of ways in which federal Medicaid dollars help states and their communities and their localities and their school districts that won't necessarily show up on, you know, a dashboard of state Medicaid spending. If you look at the dashboard of state Medicaid spending, you can see, well, here's how much we spend on kids, here's how much we spend on disabled children, here's how much we spend on parents, here's how much we spend on disabled adults, seniors, expansion adults, etc. Once you start following the money, though, then you need to start asking these kinds of questions. So the Medicaid dollars, whether it's for medical care services or economic development or long-term care services, they go to providers, whether it's hospitals or clinics or individual practitioners or nursing homes. And those providers, among other things, represent jobs in their communities. Pharmacies, you can go right down the list. So what are the implications of reducing the flow of federal Medicaid matching dollars for regional economic development? One of the things that Medicaid dollars do, because the system's still a little bit inefficient, is pays for a lot of emergency room care. Well, it would be great if we could reduce the unnecessary use of emergency rooms. On the other hand, the revenues help emergency rooms operate. So how does that work for our level 1 trauma centers, for the other emergency capacity in the state? What happens if federal Medicaid dollars start getting withdrawn after you hit your allotment? We've talked about public health, the opioid epidemic. There's, and of course, I'm not going to educate this audience about how Medicaid dollars help pay for mental health and substance use treatment. There's a whole set of issues around the tribal health delivery systems because the federal government pays the entire cost of services received at tribal health facilities, not just 50%, 100%. And what happens if some of those funds dry up? Again, depending on the state, depending on the community, depending on how the educational system is organized, some of the services delivered in schools to kids with special needs, or even to kids just for primary care services, those are funded in low-income communities with federal Medicaid dollars. What happens if those dollars tighten up? Graduate medical education. And then the other thing is federal money is a source of revenue for a state. If the state needs to borrow money, it needs to go to the credit markets. So somebody needs to have a conversation with the credit agencies about what the impact of reducing federal Medicaid dollars would be on the state's ability to borrow. Go ahead.
Yeah, I think this is a great slide because it really does show how far out the effect of Medicaid budget is on the state. It really does affect the entire state budget. It affects the entire state economy and local economies.
Okay, so I think we're coming near the end here. So we can stop talking. You can start asking questions. These next two slides will set up the next two webinars, because the mechanism for Alaska to get a block grant now, if it doesn't go to Congress and ask for it and get it from Congress, is something called the Section 1115 waiver. It's in the Social Security Act. It gives the Secretary of Health and Human Services, which of course runs the Center for Medicaid and CHIP services, the authority to waive state Medicaid plan requirements in order to allow states to demonstrate other ways of running their Medicaid programs. And there have been lots of examples of 1115 waivers that have been granted over the years, as Dennis mentioned, starting in the even before the mid-90s. And not just in the Medicaid area, but also on the welfare side as well. So there's a long history around Section 1115. The key to an 1115 waiver is that there's a set of requirements in the federal statute. If a state wants federal matching dollars, it has to meet those requirements. This waiver allows some of those requirements to be waived so that a state doesn't have to meet them, but can still get federal matching funds. Okay, and in order to do that, as a demonstration, the Secretary has to find that it's likely to assist in promoting the objectives of the federal Medicaid statute. These demos are initially approved for 5 years. At state request, there's a 3-year extensions, and the demonstrations have to be budget neutral from the federal government standpoint. We'll talk more about that, but the basic concept is the federal government doesn't want to be spending more in its Medicaid matching funds if the demonstration goes into effect than it would if there were no demonstration. So it's budget neutral to the federal government. Dennis?
Yeah, this really is kind of the teaser slide to get you all to come back for session 2 and 3, where we really get into the meat of these things.
Okay, so last slide. So can the Secretary allow a state to demonstrate a Medicaid block grant? This is what Dennis and I are going to disagree on. I just got a prompt that my connection is unstable. Is everybody able to hear me?
Yeah, I'm hearing you okay.
Okay. So, and of course, there's disagreement, and not just between Dennis and me. So one view of that language we just looked at is likely to promote the objectives of the Medicaid program in the Secretary's judgment. One view is that this gives the Secretary very broad discretion. And pretty much whatever the state asks for, as long as it's budget neutral, the secretary can approve it. And on the other side of that is my personal view, which is that the secretary doesn't have the authority to waive the financing provisions of the Medicaid statute, those that go to the matching, the open-ended matching nature of the program, or the formula. In Alaska's case, it's 50%. So I don't think that there's authority to do that under Section 1115. And in addition, to waive the individual entitlement in order to make a block grant work, I don't personally think that would be likely to assist in promoting the objectives of Medicaid, which is to make medical assistance available to people who need it. So I think you'll have to assess your litigation risk. There'll be some oversight risk. And Dennis, let's go to you.
And I agree that the Secretary's authority is not unlimited. And I think consistently through Democrat and Republican administrations alike, the lawyers counsel that the Secretary cannot waive the FMAP provision. So we cannot increase your FMAP. And we cannot decrease your FMAP. I think as I said, the rest of this are teasers for our next discussion. I think, again, talking about where states have received waivers on, and will make for, I think, interesting discussion for you all. And so come back for next time.
So I just want to add to Dennis's point, FMAP, when he uses that acronym, which is one of the many amazing acronyms in the Medicaid program, he's talking about the matching rate, the statutory matching rate. FMAP stands for Federal Medical Assistance Percentage. So it's an actual percentage, like in Alaska's case, 50%. For most populations, and then for the expansion population, next year it's going to be 90%. But the FMAP is Federal Medical Assistance Percentage.
Great. We can go to the questions that we have. I'm going to go by the orders of the upvotes. Right now, the top one with 13 upvotes is, would this replace the Medicaid waiver? I'm going to assume that you're talking about the 1915C home and community-based waiver. There's actually several home and community-based waivers that serve different populations with disabilities and older adults, including the Alaskans Living Independently, or the ALI waiver, and the waivers that target individuals with intellectual and developmental disabilities, the IDD waiver. Dennis, I'll throw this one to you.
I'm not certain whether the question is about would Alaska presumably fold their existing home and community-based waivers into the overall block grant. Again, I think that is where a level of discussion about what populations get included or not included. Would you include only the expansion population? So it's a question to be discussed. Do you put your entire Medicaid program into a single waiver or only parts of it? And the single, putting everything in, there are examples of that. We mentioned previously in the slide what New Hampshire did, but it didn't last very long. Vermont put its entire population in. Arizona, its entire Medicaid population is a Section 1115 waiver, including all of the services. But, excuse me, and as I said, we get into this in the next session. It is up for discussion which parts actually would go into the 1115.
Okay, great. Then the next question will say, can Alaska concurrently remain enrolled in the current Medicaid plan and also obtain a block grant for a subpopulation? And I'll throw this one to Andy.
So it sounds like that's the question Dennis just answered.
Yep.
It's a design question, right? You need to figure out which populations you're targeting and which services you're targeting. Are they home and community-based services or not? They're either in or out. But that, at least in the negotiations that people seem to be contemplating, that would be something to be discussed between the state and the department.
Okay. The next question is about whether you can elaborate on no entitlement for any individual. And this came up originally after one of the early slides. So I think people are wanting basics in terms of what it would be having an entitlement under the Medicaid program and versus not potentially having an entitlement under a block grant. And I'll throw this to Dennis first, and Andy, you can throw in any follow-up comments that you want to have.
Yeah, I think, again, this is an area that the courts would ultimately decide. I think that the entitlement is a very, very bright line for mandatory populations. So again, every state has expanded Medicaid beyond what the federal statute actually requires a state to do. So again, A, Medicaid itself is optional. State is not required to participate, although every state does. B, there are mandatory populations in which a state is required to cover as a condition of participation. But then beyond that, there are populations that the states choose to cover. And it's on those it's on those choice populations that I'm not certain where the court would come down, because you could file a state plan amendment tomorrow or a waiver amendment tomorrow. Again, home and community-based waivers in general, I think Alaska is the same as here in Arkansas. On the eligibility side, those home and community-based waivers are allowing you to cover people at higher income levels than generally what would otherwise be covered under the state plan. The state is under no obligation to continue that waiver. So if a state doesn't have to continue a waiver, while that waiver is in effect, yes, that individual entitlement is there. But what if the state chooses not to renew a waiver? So this is where I think the discussion on individual entitlement, as I said, I think it's a very bright line clear on the mandatory. On the optional, I'm not so certain it's so clear.
Okay. Andy, did you have any follow-up you wanted to add?
Well, let's hear some of the other questions. I want to get to some of it, because this could be a longer conversation. Yep. I mean, the one thing that's clear is there will be litigation on this. I don't, like Dennis, know how the courts will come out, but I can guarantee you the courts will be asked.
We're in passionate agreement on that.
So we can be certain that the one group that will benefit will be the lawyers. So the next question is just discussing a little bit more about the 1905B 100% FMAP for the IHS programs addressed in a block grant scenario, and just that's very important for Alaska. I know, Andy, that you raised that in the slides, that's an important consideration, and I think people are very interested about how that potentially could be impacted. Because we have another question that's saying, you know, how would a block grant impact Alaska Native populations at 100% FMAP'd, and would that be capped also? And let me see if we have any more about those ones. And I don't know, Andrew, if you see any others about the Native Americans, but I think those are the two, or Native Alaskans.
So let's be clear. What happens now in the Medicaid program, both in Alaska and any other state with significant IHS or tribal facility presence, is when those facilities serve a Medicaid beneficiary who's American Indian or Alaska Native, the state pays for the service under the state's Medicaid plan, and the federal government reimburses the state for 100% of those costs on an open-ended basis. So the issue for a block grant design is, do you want to change that? And if you do, certain implications follow. I don't think they're particularly good. But if you don't, then you need to carve out those expenditures from the block grant and say, whatever this fixed allotment is, it does not apply to spending at these facilities for these populations when they're eligible for Medicaid. We want to keep the status quo in place for those transactions, and so those should be outside of the block grant. It's a variant on the theme that Dennis articulated earlier. You have to think about which populations you're covering and which services you're covering that are going to be subjected to the federal allotment.
Okay, I'll close those ones out. And then got several with that. We've got one about how long is the contract on a block grant, and will we be locked for 10 years, for example, for the increase for services. So we've got a few on that, and Andy did talk about for it's on 1115, it would be initial 5 years and then could be renewed for that there is some ability to be able to pull out of a block grant. That's going to be talked in more detail in the later seminars. So I will just close those questions out. Next question, would the vehicle be in 1115? If so, would statutory change be required since the payment and the administrative elements of 1902 may not be waived under an 1115? With a follow-up comment, and what might you anticipate might come out of OMB regarding the pending guidance that is there? And Andy, did you want to take that one with Dennis adding follow-up?
Okay, so we have to get just slightly technical in terms of the Medicaid statute. There are three provisions that you need to worry about here. There's 1902, 1903, and 1905. And I'll just give you the bottom line. The Secretary's authority under Section 1115 to approve demonstrations gives him the authority to waive provisions in Section 1902. In my view, there is no authority to waive anything in 1903 or 1905. Okay, so what's the implication of that? 1902 is where all the rules are. We call them state plan requirements that states have to follow if they want the federal government to match their spending for eligible services for eligible people to qualified providers on an open-ended basis. Those are the state plan requirements. The Secretary can waive those if, in the Secretary's opinion, it's likely to promote the objectives of the Medicaid program. There's no dispute about that. There's some dispute about, as Arkansas and Kentucky know, there's some dispute about what's likely to promote the objectives of the Medicaid program. But let's set that aside. Now, the matching formula, the fact that the federal government is matching state expenditures on an open-ended basis, the rate at which the federal government matches, all that is in sections 1903 and 1905, all those financing provisions. Secretary can't waive them. That's why I think if you want a block grant, go to Congress. Congress can change 1903, they can change 1905, can change 1902 for that matter, But the Secretary can't waive 1903 and 1905, and that's where the entitlement to states is. That's where the matching payment formulas are. That's where the requirement of a matching payment, and that's where the open-endedness is. I don't think you can waive it.
Dennis, did you have any follow-up on that?
Well, it gets a little too technical, so I don't know. I don't want to take up a lot of time about whether or not 1902 can, to what extent, another section of Title 19. 1927, for example, dealing with the prescription drug program. Arguably, there is, if the lawyers try to make connections between 1902 and other parts of the statute, again, it's the construction of the statute. But again, I agree completely with Andy that the Secretary does not have the authority to change the match rate. The Secretary simply does not have that authority.
Okay. And for those of you who want to go further in the weeds on this issue, on session 3, when we talk about the key considerations for negotiating the terms and conditions, we'll be talking in more detail about the individual statutes that could be waived or not waived. So you'll have an opportunity to discuss this in greater detail. Okay, we've got then a question about, please provide more info on why Rhode Island renewed their demonstration but not the global cap. That seems worrisome. If it was working well for the state, wouldn't they have continued that component? Maybe I'll throw that. Andy, are you more familiar with that?
I'm sorry, I don't know the details. I mean, I could try to find somebody from Rhode Island. I just don't know.
Yeah, or Dennis, do you know?
I really don't know offhand.
Okay. So we'll add that we're maintaining a list of questions that we do not know that what we're going to do is follow up research for. So we'll add that to that list and we'll post that on the Trust website. By the way, as an FYI, the Trust will be putting a recording of this conversation in case once was not enough for you. And also the slides will be posted there too. Okay, the next question is, if a state wants more flexibility in determining who they cover, do block grants allow states to make eligibility standards higher, but only with the same amount of federal dollars? Or would the block grants allow states to make eligibility standards higher and give more federal dollars? Dennis, did you want to take a first shot at that one?
Well, it is clear 1115 waivers have been used to raise income thresholds and make people who are not otherwise eligible for Medicaid in the past, before the ACA, childless adults, if you're not disabled, not elderly, generally were not eligible for Medicaid. However, a number of states, including my old state of Wisconsin, used 1115s to expand to higher income levels. So that's a definite. But as Andy and I have both stated, it is not going to allow you to get more money. You can, and we'll go into this in greater detail, a waiver, the budget neutrality is calculated with and without the waiver. So with the waiver, the federal government cannot spend more money than it would have without the waiver.
Okay, and Andy, did you want to add anything to that?
No, just this is right. Once you move, again, to a block grant, you've got a fixed allotment. And it's got to be budget neutral, as he points out. So inside that fixed allotment, it's a zero-sum game. You can raise eligibility levels for some populations, but unless you want to be spending a lot more state money, you're just going to have to find some other way to reduce spending.
Okay. I'm going to switch to the next question. Who specifically at the state level and under a block grant would be determining how funds would be used and whether or not limited to healthcare or expanded to food, housing, etc.? Andy, do you want to take that?
So I think under a block grant, and correct me if I'm wrong, Dennis, it would still be the state Medicaid agency, the single state agency, that would be responsible for the receipt and proper expenditure of the federal Medicaid matching funds. And they would run the state Medicaid plan, and if it were waiver were granted, they would be in charge of administering the waiver. So I think it's your single state Medicaid agency. I guess that's the Department of Healthcare Services in Alaska. And they would make the decisions, and of course those decisions would have to be within the guardrails of whatever the waiver specified in terms of allowable uses of funds.
Okay.
Yeah, I agree with Andy that it has to come from the agencies the agency that administers Medicaid. Nobody else can do it. I think you triggered a question in my mind that I don't know, which is how much authority does the governor have? So I remember in Ohio, the governor did not have support from the state legislature to do the Medicaid expansion. He did it under his own authority. So I don't know if your governor has that kind of power to be able to bypass the state legislature. Now, of course, the second time around, because the state legislature has to appropriate funding, eventually it had to come back to the legislature. But the initial one, I don't know, because I don't know the power of your governor.
Move on to the next question about how would a block grant scenario interact with EPSDT requirements? And I'll throw that over to Dennis.
This, I think we will again address this into the later sessions because EPSDT is a mandatory service. And to my knowledge, it's been waived only once. And that was in, I don't know how familiar people are with the Oregon. But I still tend to think that any secretary, Democrat or Republican, would be very hesitant to waive a mandatory service. And if they did, again, I think that unquestionably would also go to court.
Yeah, let me just say, I agree with Dennis on that. It will definitely go to court. So EPSDT, Early Periodic Screening, Diagnostic, and Treatment Services, it's sort of the Cadillac pediatric benefit in Medicaid. It's a classic example of an individual entitlement to a defined set of benefits. And it's mandatory, as Dennis points out, as are almost all of the child populations who are entitled to EPSDT services. They're also mandatory. So that is, what would be at issue legally. The problem is, in a real block grant, you can't have an individual entitlement. You either have to have an enrollment cap or some other way to limit your spending as a state, because the federal government is limiting its.
Okay. I'm going to move on to the next question. This one asks, block grants give states more flexibility in who to provide care to and what care to provide, but ultimately the Medicaid program's purpose is to provide access to health care. So my question is, what oversight and evaluation will the federal government exert over a Medicaid state plan for a block grant? Are there still some expectations for maintaining the purpose of Medicaid and to protect access to health care if the state plans to effectively reduce access, deny access to medical care for certain populations, or reduce access, deny access to certain types of medical care? And Andy, I'll throw that to you first.
Well, the federal government would still have the obligation to make sure that the funds that were distributed on a block grant basis were spent in the way that the terms and conditions of the waiver specified. So at that basic level of program integrity, yes. In terms of monitoring access, that would depend what the requirements were in the block grant. If, as under current law, states, are required to provide, make payments to providers that are sufficient to ensure reasonable access, then, and if those terms are still in the block grant, then yes, the federal government would have some oversight responsibility. But if not, if the philosophy of the block grant is, we're going to let the state, the whole point is to give the state more flexibility. It's closer to the people it's serving. It can decide whether there's access or not and how important that is to it. It's all a question of the design of the
program. Okay, and we have a kind of somewhat related about would the state remain under all the federal oversight, i.e. upper payment limits, audits, et cetera? So Dennis, you wanted to?
Well, again, I think those would be spelled out in the special terms and conditions, or the STCs. So again, what gets waived, that would be all part of the negotiation process. And picking up on the last question as well, an evaluation is a requirement of 1115 waivers. Now, obviously, the breadth and depth of that evaluation may be called into question, but there is an obligation to that. And as Andy said, certainly there's going to be an obligation to maintain program integrity.
We are at about time. I want to see, we've got a few more questions. I think we could probably answer them within 15 minutes. But I want to check and see if Dennis and Andy and the trust are okay for us to go over about 15 minutes.
I'm fine.
Dennis, are you okay for it?
I pretty much have a hard stop at 2, which we're almost at, but I would encourage you to continue if you can.
Okay, we'll continue, and if we see I'll do my best to try to channel you somewhat, but if there's points that are raised for that, then we'll keep notes on that so that, Dennis, that you can then respond in the next 2 sessions. And also, I should first check and see, Kelda, is it okay with the trust? Is it okay to have the room for another 15 minutes? I'll assume that it is.
Well, I am going to jump off, but thank you so much for including me. And Andy, what a great job you did in presenting, and look forward to the next session next week.
Great. Thank you.
Likewise, Dennis. Thank you.
Okay. So the next question is that I can see that block grant benefits the federal government because it caps their portion of the Medicaid spend, but what are the advantages for the state? Would it waive other Medicaid requirements on a broad basis? If so, would a state still be required to comply with what would the state be required to still comply with as it designs a program under the block grant? I'm thinking, Andy, that one is when we get to the terms and conditions for session 3. That'll give us a better chance to talk about that in greater detail because it does seem like a longer question. Would you agree?
I agree.
Okay. And Andrew, I'm noting that there's a question that's specifically in there about something that Dennis said. Can you copy that one in for us to address then on the next session so Dennis can respond to that directly?
Certainly.
Okay. Next question, can the state participate in the 1915 program and the block program for the areas that the 1915 does not cover? I believe that we've addressed that in that you had said that it could be part of negotiating. The 1115 would be determine which populations and programs are included or not included. Andy, did you want to add anything more to that?
No, that's basically the answer. Just so people should understand, there are some pieces of the Medicaid statute, like Section 1915C, which is the authority for the original authority for home and community-based services waivers. And there are mechanisms built into that section of the statute to make it optional for the states to cover the population, to allow the states to cap enrollment for those particular services for those populations. That's all in there.
Okay.
And what we're talking about here is not in the statute. And it affects, as Dennis has said, mandatory populations, mandatory services. 1915C is neither mandatory population nor mandatory service.
Okay. I want to acknowledge the question that we have that has the most upvotes at this point is, why would the state consider something that would force them to remedy all of these risks on their own without federal funds or assistance? It doesn't make sense to me. I think that's, one of the reasons why we're having this, to explain and explore the pros and cons so that the state and the stakeholders can make sense to that and consider that when answered. I'm sure that Andy would thoroughly agree with you, and I don't think it's fair to give him a chance to respond without having Dennis on there. Okay, then the next one that has the most votes is this affirms the mantra that Medicaid is not rocket science, it's more complicated than that. I would thoroughly agree with that. And it actually is the comments made by somebody who probably knows that better than anybody else. Next comment is, or question, is it true that community first choice in the 1915C waiver, the federal allotment is greater than the state share in Alaska? So I'd clarify that for community first choice, that the state is receiving enhanced match for that. That is allowed under the Community First Choice program. It's not, they do not receive the enhanced match for the 1915C waiver, but they do receive that under Community First Choice. I guess maybe if we reframe that question, and this was posted anonymously, so whoever asked that question, please tell me if I'm not getting at the core component, but maybe the key question would be, how would the enhanced match that the state is getting under Community First Choice be impacted if the state was to go with a block grant?
If the state included the community first choice population and services under the block grant allotment, then for those services and populations, the match rate would not be changed for those particular services, because again, Congress has gone in and said, for those community first choice services and populations, we're going to provide a greater match. And that's in the statute, no question about it. And the federal government knows that, the states know that, and those are the terms.
But it seems like operationally it would be more challenging because you would have potentially the pool of dollars that was negotiated under the budget neutrality for the community first choice side, the enhanced match, and then what the actual spending is under that versus the rest of the block grant, and then monitoring that and the performance over the 5-year period. That might be something, Andy, to.
No, it would be complicated, and you'd have to blend the match rates, right?
But even if because this is a small portion of the overall spending, so yeah.
There would be there would be operational issues. How do you identify those particular expenditures so you know what you're matching? And that goes to the program integrity issue. And then depending on where the allotment amount was set, you might get there faster than you otherwise would if you're drawing down at a higher match rate.
Okay. The next question is, would the Alaska Legislature have to approve any block grant or 1115 waiver, or could it be done by the administration? I'm assuming the state and own. On that one, I think that's a legal issue within Alaska on their particular areas on that. So we'll give that to the trust. You know, I'll have Andrew track that to the questions that we couldn't answer to that and give it to the trust and see if they have anybody that can provide a clear-cut answer on that. Okay. Next question is, if a state wants more flexibility in determining who they cover, do block grants allow states to make oh, never mind, we already answered that one. Before the next session, can someone please troubleshoot why some of the thumbs ups and icons, some see the thumbs up icons and some do not? I'd like to be able to show the support. Okay. I'm not certain why you're not able to see the thumbs up icon. It should be showing up to your, and it shows up, it's kind of subtle. On the bottom side of the question on the left, so it can be fairly highlighted. And I see somebody, I just selected that, but I'm sorry for the technical issue that you might be having. Next question is, where can we access a list of the mandatory populations? And Andy, and you're talking about from the federal mandatory populations, do we have a list of that? I'm trying to remember if we have a list of that.
Yeah, I'm virtually certain the Kaiser Family Foundation has a list. I will track it down for you. Okay,
great. Okay, and down to the last question. Actually, and that one was already answered. So we are done with all of the questions.
Steve, this is Kelda. We do have some questions here in the room.
Sure, go ahead.
I'll read a couple that were passed to me. Alaska is currently pursuing an 1115 to reform the behavioral health system. How would a block grant affect that process?
Yeah, so you've got an 1115 waiver, and we'll talk already for a certain set of services for certain populations. And this is sort of the classic use of Section 1115 to make federal matching dollars available to states to try out, in this case, new ways of delivering services to people with behavioral health and substance use conditions in different settings than they otherwise would. So that, in theory, could be just set off to the side and continue to run separately if the state decides to go ahead and apply for a block grant under a different 1115. It could, in theory, submit an amendment to the waiver it's gotten now. It has approval for this behavioral health amendment. It could submit an amendment to that approval to bring additional other populations into a block grant. It could have a freestanding block grant proposal. It's got options. It could take the freestanding block grant proposal and move the existing 1115 into it if it wanted to. So again, you come back to the question of why would the state want a block grant? What are the risks? What are the benefits? And then once you've gotten through that, how would the existing waivers we have, whether they're 1915C waivers, other 1915 waivers, whether they're the existing 1115 waiver that you just got approval for, how do those relate? But you got to start at the beginning, which is why do we want a block grant in the first place? What are the pros? What are the cons?
Another question that we have is, how would a block grant impact rural and, for Alaska, what would be considered from most of the country to be frontier area? What would be the specific impact on those very remote locations, or potential?
Yeah.
We don't.
Well, that of course would depend on the design of the block grant. The one thing I can say, without fear of contradiction, is if there be fewer federal dollars available, because that would be the point. Fewer federal dollars than under an open-ended matching arrangement. And you can take a look at the Catholic Hospital Association estimate just for children. But there would be fewer federal dollars for the state to work with. Then the question is, go back to the follow the money slide. In terms of economic development, sustaining rural providers in those areas, addressing behavioral health or other needs in those remote areas. If those are higher cost undertakings, that will put additional pressure on the state within the allotment.
Okay, those are all the questions that we have here in the room.
Okay, and we just got one other one that came online. That would this be an option to support individuals with mental health issues not otherwise covered under any of our 1915 programs? So Andy.
So yeah, again, depending on how you design the block grant and which populations you want to include and which services you want to include, then yes, you could make room for other populations, but you'd be operating inside a fixed allotment. And it would be a zero-sum game under there.
Okay, great. Well, thank you for all of the people who made it through to the end. We actually topped out at about 233 people online. There was an additional 45 people on the phone. There was probably some overlap of those on the phone versus online. We appreciate your interest, and we hope that many of you can join us for sessions 2 and 3.